Good afternoon. This is the Health Commission Community and Public Health Committee meeting of Monday, July 21st, 2025.
I will call the roll. Commissioner Dorado
Present.
and Commissioner Guggenheim.
Here.
Thank you again for sitting in the meeting. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, the approval of the May 19, 2025 committee minutes.
I so move approval.
Second.
Is there any public comment in the room on this item? And there's no remote public comment that's been approved. So all those in favor?
Aye.
Aye.
Great, thank you. We can move on to item 3, supporting children and youth with special health care needs. Okay, you can see it over there.
Oh, perfect. Well, I know Aileen Armstrong is on the elevator right now. She's the Director of Maternal Child Adolescent Health, and she was going to discuss a little bit about the 17 programs within Maternal Child Adolescent Health Division in the San Francisco Department of Public Health. Here she comes. You want to step right up and just start?
It's perfect timing.
Okay, good afternoon. Just get my note from here.
And please, I was just letting them know, please enunciate close to the microphone and a little louder than normally might, because the sound in here isn't wonderful.
Okay. Good afternoon, Commissioners. My name is Aileen Armstrong, and I serve as the Director of Maternal Child Adolescent Health Section. And MCH is under the Ambulatory Care Division within our section.
Or would you like me to begin, or would you like to? Okay.
I would like to start. Go ahead. You can start the
Here we go.
PowerPoint.
Yes.
Okay, can say right there. At MCH, we oversee 16 dynamic and impactful programs focused on improving the health and well-being of MCH families across San Francisco. Our work spans to prenatal and postpartum care, early childhood development, family planning, and adolescent health, and children with special health care needs. Today marks an important milestone in our journey to close long-term standing gaps in care and resources for our children and youth with special health care needs. This is a moment that has been a long time coming. We are thrilled to be part of a city that is stepping up to invest meaningfully in systems of support, systems that not only provide services, but also elevate the voices of our families, placing their lived experiences at the center of how we design and deliver care. MCH is proud of the work that we have been doing for the past decades. With that, I am honored to introduce someone whose leadership has been instrumental in this work. Dr. Ben, our Children's Medical Director of California Children's Services. Dr. Ben Mizell brings both clinical expertise and a deep compassion for families navigating complex care systems. Today, he will be sharing insights on the Children and Youth with Special Health Care Needs initiative and what it means for the future of care here in San Francisco. Please join me in welcoming Dr. Ben.
Thank you so much, Aileen, and thank you to the health commissioners for this opportunity to present the work of MCAH to support families of children and youth with special health care needs. Again, my name is Dr. Ben Meisel. I'm the medical director for California Children's Services, which, along with Family and Children's Services, formerly known as foster care, make up the Department of Children's Medical Services within MCAH. As Aileen explained, the MCAH division is composed of more than 15 programs which share a common function of providing critical support to the most vulnerable children, youth, and birthing people in San Francisco, from helping to put food on the table, to supporting teens through pregnancy and parenthood, to keeping foster youth connected to care, to help pregnant people who are on the streets get back on their feet and keep their babies safely in their care. These are safety net programs without which our highest risk families enter even more dire scenarios, exactly what the mayor has prioritized addressing in our city. I'm here today to talk about the particularly vulnerable group of families in San Francisco that have children and youth with special health care needs, and the critical work California Children's Services and MCAH do to improve care, reduce cost, and improve public health for these San Franciscans with uniquely challenging lives. Next slide, please. Oh, is there one before that?
Yes.
Okay. I want to start by taking a moment to humanize and bring to life the people we are talking about when we use the acronym CYSHCN, or Children and Youth with Special Health Care Needs, to make sure we're all on the same page. Children and youth with special health care needs are individuals with a very broad range of disabilities and complex medical needs who also require health and related services beyond those required by children generally. And the data shows that these children and their families are not doing very well. Next slide. Here in San Francisco, it's estimated that about 26,000 children have special health care needs, or around 15% of children here in our city. It is also the case that according to the California Health Interview Survey, approximately 88% of these children are not receiving care in a well-functioning system. Next slide. We need to do and can do better in San Francisco. The San Francisco Department of Public Health holds the mission to protect and promote the health of all San Franciscans. The Maternal, Child, and Adolescent Health Division within SFDPH is tasked with assessing and serving the needs of 5 domain populations, and children and youth with special health care needs is one of these domains. MCAH thereby provides services and collaborates with partners to improve the system of care for children and youth with special health care needs in San Francisco. Next slide, please. The 2 children's medical services programs within MCAH are state-mandated programs requiring oversight by health providers. Whereas MCAH is primarily connected to the California Department of Public Health, the children's medical services programs connect maternal, child, adolescent health to the Department of Healthcare Services, as with CCS, and the Department of Social Services, as with the Family and Children's Services, or FCS. Let me define CCS. CCS is a state-mandated public health program serving children on Medi-Cal with medically complex conditions that require pediatric subspecialty physician care. Our public health nurses and dental hygienists case manage these patients and guarantee access to the pediatric subspecialty physicians that are most appropriate for care of that child's specific and often rare medical condition. Each county must have a CCS program. San Francisco's CCS program serves between 1,500 and 1,600 children who have complex medical conditions and receive Medi-Cal. Around 250 of these children have qualifying orthopedic or neuromuscular conditions that make them eligible for our medical therapy program, which provides expert occupational therapy and physical therapy at 3 CCS-run, San Francisco-based medical therapy unit clinics. One is in the Sunset District, one is near City Hall, and one is in the Bayview Hunters Point. Our therapists are experts in helping our equipment-dependent children get the specialized durable medical equipment, or DME, and bracing that they need to access their community. Next slide, please. Here's an example of how CCS might work to improve the care of a medically complex child with Medi-Cal in San Francisco. So take an 8-year-old child with mucopolysaccharidosis, which is an enzyme defect that leads to a buildup of proteinaceous material in all organs and systems of the body. These children become developmentally disabled. They have problems with their joints because of the buildup of material, and they often have problems with their muscles. In this case, this is a child who has heart failure, who's going to need a heart transplant. And in order to do that, he would have to go to Stanford, Lucile Packard Children's Hospital, which is the only pediatric center for heart transplant in the Bay Area. And then they would have to get enzyme replacement at UCSF. And as you might know, as health people, to be able to provide care between healthcare systems that don't talk to each other is virtually impossible. And so within CCS, we're able to authorize the care to specific specialists regardless of the center. I can send them to CPMC, we can send them to Stanford, we can send them to UCSF, et cetera, just to make sure that they're being seen by the right people. So let's give you an example. Our eligibility workers and clerical staff, they would intake the kids, make sure that their families have residence in San Francisco and that they're financially eligible, and they would even help get them connected to Medi-Cal. Then our physicians, like me and my medical partner, we review the case very thoroughly and determine which specific medical providers should be providing care for that child's specific conditions. And we make sure to let the nurses know, here's the care that we should be authorizing. The nurses then contact the families and they're able to authorize all of that care so that when the family shows up at the doctor is actually able to see the patient and they'll actually room them instead of sending them away. Our social worker then assesses the families for their social determinants of health, and if they have food insecurity, homelessness, housing issues, violence at home, et cetera, she's able to help them get the services that they need that way. And then our physical therapists and occupational therapists at the medical therapy program are able to make sure that that child has the specialized wheelchair that fits that child and the specialized bracing that enables them to stand up and walk around and access the environment at their home or in the community. Next slide, please. The work of CCS is critical for a small subset of the most medically complex children in San Francisco. But across all severities of disability and all incomes, there are many more children with disabilities in San Francisco outside of CCS who MCAH is dedicated to serve. Next slide, please. By the way, this is a slide of, it's a visual note-taking that we did during a session with families in order to assess the needs of the children with special healthcare needs in some of the most underserved communities in the city. Over the many years in MCAH that I've been there, it's become clear that San Francisco has been a resource-rich, coordination-poor city for families of children and youth with special health care needs. We've worked in the past to identify barriers to care for families with children and youth with special health care needs, and through multiple initiatives, attempted to pull together agencies and organizations in order to assess and attend to the needs of these families with varying degrees of success. We were building some positive momentum for these efforts when, in 2020, during the COVID pandemic, all of the leaders of these efforts were deployed to COVID response. This led to services and supports falling away for families with children and youth with special health care needs. In fact, for a number of these families with children on ventilators or who needed around-the-clock care, especially those who were monolingual Spanish or Cantonese speaking, after many months into the pandemic, we finally found out that many were suffering from hunger, unable or unsafe to leave their home to access food. So next slide, please. So a more strategic and sustainable approach to bringing together families and agencies serving children and youth with special health care needs was needed. And to tackle this challenge, MCAH partnered with the city's only family resource center dedicated to serving all children with disabilities, regardless of disease severity or family income. That organization is Support for Families of Children with Disabilities. Given that public health emergencies disproportionately affect people with disabilities, we propose to build an interagency collaborative focused on children and youth with special health care needs that would not be disrupted by a future public health emergency. Together with Support for Families, we at MCAH applied for and received a 3-year Children and Youth with Special Health Care Needs Innovation Grant from the California Department of Public Health, where only 5 of these were awarded in the entire state. With this money, we created SF Kids Collaborative. Next slide, please. SF Kids is an interagency collaborative that brings together partners across San Francisco that serve children and youth with special health care needs. From the very beginning, families have been and continue to be at the center of this effort, and partners across the city have been engaged. MCAH provides the funding for staff stationed at Support for Families, including a director for the program who serve as the backbone team managing the effort. This is important as they can remain in place even during, especially during, public health emergencies to ensure that the agencies that serve children and youth with special health care needs continue to be present for families when they most need it. Next slide, please. The results have been tremendous. And before I go further, I want to recognize the families that have served in the collaborative and the many partners across all of San Francisco that are now coming together on an ongoing basis and sustainable basis to listen to families and help make the system work better for them. It is important to us that we continually restate our mission and our strategic pillars to keep our broad collaborative focused, and you can see those here. To build capacity to center families, improve coordination across systems, create a sustainable collaborative, and develop the data capacity of the system, which is our next hopeful step in this process. Next slide, please. It is also important to share just a few quick highlights about the structure of the collaborative and how it actually functions day to day. Each circle in this diagram is a different set of SF Kids meetings. The small upper right green circle is family meetings monthly. I want to reiterate that families are at the center of everything the collaborative does. They get the first and the last say in our meetings. We historically have had approximately 20 families participating as members of the collaborative at any given time across English, Spanish, and Cantonese language groups. We meet with them several times per month in community gathering and affinity space meetings to build relationships and capacity for engagement. In the small red circle, those are our work groups. We have multiple work groups. Currently, we have 3 really active ones: the early intervention, complex medical conditions, and the transition-aged youth group. We then bring these families together with professionals from our partner agencies across San Francisco in monthly workgroup meetings, which are critical forums for driving our collective impact forward. And that's what led to the creation of those resources that are in the packets that you have in front of you. The small orange circle is the core team. There are 4 to 5 of us who come together weekly in order to manage the SF Kids Collaborative project. And then the large green circle are all the agency representatives and families, and we come together 3 times a year in triennial meetings. Next slide, please. Speaking of partners, we are thrilled to have such broad representation from partners across San Francisco that are engaged in the work of improving the system for children and youth with special health care needs. Here's just a few of their logos on this slide. Next slide, please. Speaking of the work we've been doing, you can see again some of the resources we've created in the folders we've prepared for you. As a reminder, each one of these resources was, number 1, requested by families and driven by family input. 2, created with cross-agency collaboration. 3, is available in 3 languages: English, Spanish, and Chinese. And 4, is being distributed through partners in the community where families are. Next slide, please. In terms of quantitative outcomes, a few SF Kids highlights include: we now have over 200 current participants on our collaborative roster, and it sounds like we'll have more from CPMC and Stanford, thanks to Suzanne, representing 50 organizations across San Francisco. 32 local families have served as participants in the collaborative since inception. To date, a total of 9,046 people have been reached with the new SF Kids resources through the distribution efforts of partners. The SF Kids website has logged 7,700 views over the past 12 months. That's a 392% increase over the preceding 12 months. And finally, in the 2 most recent installments, November of 2024 and April of 2025, of the biannual survey of the entire collaborative membership to evaluate overall progress, 100% of respondents reported that they either agree or strongly agree with the following statement. I think the SF Kids Collaborative is making progress on its mission to improve the lives of families of children and youth with special health care needs in San Francisco by centering the voices of families from historically excluded communities in partnership with providers to effect meaningful systemic change. Next slide, please. SF Kids has been an enormous success. The state is so encouraged by our work that they have awarded us a second grant for the next 5 years to enable us to continue this work. This next grant fully funds a senior health program planner position within MCAH to build and run the interagency SF Kids data work group to solve the data vacuum that has existed for children and youth with special health care needs. We'll build the data infrastructure that has been lacking and that has made it impossible for MCAH, the Department of Children, Youth, and Families, and even Lucille Packard Foundation for Children's Health to get accurate data on the health of families with children and youth with special health care needs. Next slide, please. Looking to the future, it is critical for families in San Francisco that this work continue. We've built the foundation, proven that the model works, and have the grant funding provided by the state to continue moving forward. The Children and Youth with Special Health Care Needs Senior Health Program Planner role is incredibly important and strategic to the future of our work. Hiring this position will enable us to overcome a major void in data on the need of this population. Having MCAH lead the SF Kids Data Work Group will enable us to address the voiced needs of the children and youth with special health care needs community and track progress with clean data on the needs of families precisely at the time when Medicaid funding cuts threaten to disrupt these families' lives and the health care of their children with complex health needs. Last slide, please. In closing, I'd like to leave you with the following thoughts. Number one, children and youth with special health care needs in San Francisco and their families are struggling, and this is bad for San Francisco. Number two, the SF Kids Collaborative has emerged out of CCS within MCAH and is transforming health through collective impact for San Francisco families with children and youth with special health care needs. Number three, the California Department of Public Health provided the seed investment for this innovative project and now decided to reinvest 5 more years based on demonstrated progress. Number four, SF Kids is a force multiplier for existing agency programs and investments in this space. The model of SF Kids is collaborative by nature and focused on families by design, making it both high impact and cost efficient. Number five, support of MCAH means lower cost to San Francisco because we address the root causes of adult disease, preventing expensive health complications, crime, and homelessness. SF Kids improves our CCS case management and care coordination by improving care and preventing even a $1 million hospitalization or ER visit for children with complex medical needs. And finally, none of this would have been possible without MCAH and support for families of children with disabilities working together to serve as the critical double backbone function driving this work forward for families. SF Kids as a program is helping protect the most vulnerable families with children and youth with special health care needs, bringing partners together, reducing healthcare costs, saving money, and making our city better. And over the next several years will be critical to supporting these vulnerable families through the local, state, and federal funding challenges that will disproportionately affect these families with children who rely on Medicaid and school-based services. Thank you so much for your time today and for your service to the people of San Francisco. I'd be pleased to answer any questions you might have.
Is it okay if I'll check with public comment first? Is there any public comment in the room on this item? I see none, and there's no one has been approved to provide remote public comment. So commissioners, please ask whatever questions you have.
I know about something about Solid Start at ZSF at Zuckerberg.
Okay.
And I'm wondering how that's coordinating in with what you're doing or not.
Solid Start, is that an enhanced care management program? I'm trying to remember, are those care coordinators?
It's the 0 through 3 program to get kids all on a healthy start.
I'm not sure what Solid Start is, but I'm pretty sure, is it through the CHC, the Children's Health Clinic at Zuckerberg?
it sounds like maybe I can find some information and we can try to coordinate to see.
It
if
does. It goes with Team Lily.
Oh, okay.
Team Lily,
Yes, yes,
and then-
yes.
After kids, the families are out of Team Lily,
Okay,
they go to Solid Start,
okay.
but that group, Team Lily and Solid Start, under the Children's Health Center or together, separate, but together
Yeah.
to a certain extent, might be a good contact for the
We
collaborative.
probably have them involved, and it might be through Family and Children's Services, who works with Team Lily, and we may have a Team Lily representative in the collaborative.
But then probably should go to have somebody or whoever crosses over with Solid Start, because that's when the kids get older. And
Yeah.
when they do up to, I
Beyond
think
three.
Solid Start is up to age
3.
3.
Oh,
So
okay.
that would be
Yeah,
the early start, just to make sure
yeah,
that they're part of the collaborative in the package.
we'll make sure Solid Start is part of that. Yeah, sounds like a perfect match for the families that should be involved.
So I have just a couple more questions. I'm
Please.
so glad you and I met beforehand, and thank you, your, staff for all answering all of my previous questions, which you have helped clarify for me. But one of the things that I always get most concerned about is, yes, you have, been able to reach lots of families so far. But for those, I mean, it's almost like a marketing thing of what the services are or the contacts within San Francisco Kids Collaborative. When you have that graph of early start, the 3 sections there, is there a way to, and I know I had asked this in the questions, my biggest concern is pediatric offices. This is where early start, a lot of these referrals, that's their medical home. But there should be a visual, almost, inexpensive, or a, tip sheet, or we call them in another thing, of what the, those 3 areas of focus, and a contact number, because there are a number of families who are not necessarily great, real literate on the internet and on contacts. And so I know even at our place, we post things on a visual basis, and it makes a big difference. So for those that, especially for the families, which we have a lot of, that are basically unhoused and in various, not even a shelter, but they're couch surfing, et cetera. My understanding is those families, 90%, 98%, I know I had seen the figures, do have a medical home. Generally through, DPH, or through the community clinics, or St. Anthony's has a lot of these kids, et cetera, in their peds clinics, that there needs to be some sort of posting or something that's not only internet based or,
Yes.
virtual for families.
If you would look inside of that packet
Yeah.
and pull out in the back, I think, here.
Oh, there. Okay.
Was the last degree, so like actually developed this. Right, so for the
Right.
early start map, right? Something like this that actually it's oriented vertically, just because actually of the Cantonese families giving us input, because that's how that is red is
Yes.
vertically, right? So to be able to have something like this, is that what you're thinking
Yes,
of?
that's what I'm talking about, that would
Yeah.
be at, shelters, at the family shelters, at,
That's a great
Oasis Inn,
idea.
at, Hamilton, that as well as in all of the DPH community health clinics too, that, there's always places to post things. It's just, all of this is wonderful, but how do we get families that aren't super sophisticated to know
Yeah.
about what is possible? And even since it is in the 3 languages, like in certain neighborhoods, including the Sunset, et cetera, that it is also in Chinese, and in the Mission, it's in English and Spanish, and, depending on the neighborhoods. But I just think,
In the clinics in particular, like in those and the shelters. And yeah, right now we're focused on having our partner organizations be able to take them and get them to their programs. One of the places where we try to connect with those families that you're talking about are in like nurse family partnership, the visiting nurses, like they're taking them out with them to the families that they're getting to know and then explaining it to them. But it's more of it's a high touch distribution at this point, but I love that idea. And we have work to do as far as being able to actually get these out to specific physician clinics or specific health agencies.
and I think if that, with the hiring or the senior data manager, and whatever,
Yeah.
distribution could be possibly part of it, like to all of the FQHCs, not just DPH FQHCs, but it's at NEMS, it's at St. Anthony's, it's at Mission Neighborhood Health,
Yeah.
that are on the clinic consortium, because the clinic consortium obviously, includes all the pediatric clinics as well. I just think I would hate for this information not to be there. I mean,
Yeah.
if I knew about it before, I would have had this all posted in our place,
These
the
are
physical thing.
relatively new, so it's perfect timing.
Yeah. No,
And
no,
like,
that's-
and San Francisco Health Plan is a partner in all of this, and they are providing that to NEMS. That at least that was the goal, was it for it to go from San Francisco Health Plan to all of its partner agencies that are serving their kids.
which is great, but let's make sure that it happens.
Yeah. I
that
love
there's
that idea of
follow-
adding distribution to the responsibility of the senior health program planner. That makes a lot of sense, actually.
Yeah, because I mean, I just think once we get early start kind of better organized with DDS, et cetera, hopefully there will be more families being served prior to the age of 3.
I know.
So, I mean, as this task force, as I mentioned to you, that, working hard, but it's just, I want families to know if they're not sophisticated in
Yeah.
this, or, when you're, obviously, best, because CCS is a well-oiled machine for sure, is that families don't have time
Oh,
to
gosh.
be able
No.
to oftentimes go searching. So that's why
Well said.
oftentimes it would be helpful.
Yeah. I'm excited for your input in all of this too, because I think your voice has been missing in especially that early intervention work group. That's like would have been really great input to have. I mean, and we're still running. So, there's a lot of work left to be done for sure.
Yeah, it's just a continuing, concern as at least we have seen in our center, but also at our NICU. Now there's a special NICU unit for kids born from 22 to 25 weeks, those kids are going to need this most probably.
Yeah.
That, the families are going to,
Is that the high-risk
this.
infant follow-up program, or is that different?
that's inpatient, that's the
Oh, that's the
inpatient NICU.
inpatient.
And then
2225.
we have the Child Development Center at CPMC has the NICU follow-up program. Yes. So
Awesome. Thank you for that input.
yeah, we just need, it's great. And it's been, I really appreciate not only our conversation, but also the answers to my questions. And I really look forward with my other hat, but as a health commissioner, to learn more, because it's an increasing significant need.
And with Medicaid cuts, it's going to get even
That's-
scarier for these families.
Right. Mhm.
Yeah.
Yeah, it's another added burden. So Judy, do you have any other question? Okay.
Okay. And I'll look at Solid Start. We'll make sure to get them connected to us if they aren't already. Okay. So we do have a connection through our perinatal equity initiative that is part of SF Kids and maternal child adolescent health. So they are involved in our work group meetings. So they've been providing input to us. So that's good to know.
Right. Is MDAC out at General? Are they,
Yeah.
They're all part of it too.
Mhm. Yeah.
That's
Oh,
what I
yeah.
thought.
Big time.
Okay. Perfect. Okay. Well, thank you very much. And I really look forward to further information.
All right. Perfect.
Thank you.
Thank you very much.
We can move on to the next item. Item 4, investing in our people, ensuring public health capacities and capabilities. Thank you.
Great. Good afternoon,
Hello.
Commissioners.
Welcome back.
Thank you. My name is Dr. Jonathan Fuchs, and I'm the Director of the Center for Learning and Innovation in the Population Health Division. It's our Training and Workforce Development Center. And I'd like to share an update on current activities to strengthen the capacity and capabilities of our public health workforce, which is our most vital resource to implement our public health services. So next slide, just to go over the agenda. I'll provide a brief overview of our branch and then share some data to give you a snapshot of the PhD workforce, and then focuses on some key advances supported by our CDC-funded public health infrastructure grant. And then finally, I'll comment on some of our future work specifically with that grant program. Next slide. Just to situate us, looking broadly at DPH, CLI sits within the Population Health Division led by Dr. Susan Phillip, our health officer and division director. Next slide. So our division is over 530 strong, comprised of over 470 permanent and temporary civil service staff who also work in close collaboration with over 60 contract staff who largely support our research and technical assistance functions. CLI sits within the research, learning, and development pillar of PhD, all the way over to the left. However, given our training and workforce development function, CLI also interfaces closely with our Deputy Director, Daisy Aguayo, who leads our operations, people, and infrastructure. Next slide. I'm proud to say that CLI draws incredible strength from our multidisciplinary team of trainers, instructional designers, coordinators, and evaluators, many of whom are here today and online, and all of whom are committed to promoting our shared vision of fostering a culture of learning, trust, and innovation with PhD, and advancing its mission of promoting a diverse and talented workforce that strives to advance health equity. Next slide. So CLI's training and capacity building work is focused both inward at the Population Health Division and outward to local community partners, as well as nationally to support the HIV prevention workforce across the country as a CDC-supported TA provider. Today's presentation will focus specifically on our internal work that strives to help fill gaps in public health capacity and capabilities, and doing this in part through our CDC-funded public health infrastructure grant. We're currently in our third year of a 5-year award, dedicated funding through the FIG, and I'll discuss more about this grant program and its innovations in just a moment. Next slide. So setting the stage of determining what are our workforce development priorities, we rely heavily on guidance from the Public Health Accreditation Standards, which is grounded in Domain 8 of the 10 Essential Public Health Services, which is that little dark blue segment of the pie, which is focused on building a diverse and skilled workforce. We also center the foundational capabilities in public health, which is the graphic to the right, and provides a helpful organizing framework to better understanding the what we do as a division to strive and deliver effective public health services. In terms of assessment, we conduct both formal and informal needs assessment to understand training and workforce development needs. So for example, since 2014, we've taken part in the National Public Health Workforce Interest and Needs Survey, also affectionately called PHWINS. It's led by the de Beaumont Foundation in collaboration with the Association of State and Territorial Health Officials and the National Association of City and County Health Officials, also known as NACHO. PHWINS is the largest survey of governmental public health in the nation that assesses such topics as reasons staff are considering leaving the public health workforce, as well as training needs. The 2024 survey was most recently fielded last fall, and we have recently received preliminary data, which I'll share in a moment. Our DPH-wide staff engagement survey is fielded every 2 years, and this provides important insights to guide the division-wide efforts around action planning. And we rely heavily also on strong partnerships with DPH-HR to look at our data on demographics, on retention, on vacancy rates, the time to fill positions, and other key performance data. We also rely heavily on the DPH Racial Equity Action Plan to inform our workforce-focused efforts. And then the public health core competencies have been established by the Council on Academic Linkages, and that also informs our work. Next slide. So now I'd like to focus on our major priority of workforce development, looking at the diversity of our workforce and ensuring that it reflects the diversity of the populations we serve as a health department. In the top left, you'll see data provided to us from DPHR, which shows the change over time in the racial and ethnic distribution of PhD staff from 2018 through 2024. As you'll see, we see a significant increase in the number and proportion of Latine and Black African American staff within PhD. And we've also had a particular focus on our leadership positions, including branch directors and managers. And as you can see among new hires before and after 2022, a substantial increase in the number of leaders who self-identify as Latine or Black African American. Go to the next slide, please. So now I'm going to talk about vacancy rates and retention. So first on the left, you'll see data on our vacancy rates. So overall in 2024, the vacancy rate for PhD was 9.9%. This is down from an all-time high of 27% in 2022, post the emergency COVID-19 response, and an amazing effort to hire over 300 positions in that time. You will note that our vacancy rate is currently somewhat higher than DPH overall. And then when you stratify the data by different subtypes of positions, such as environmental health or operations, we do notice a higher vacancy rate for analytics and epidemiology. And because of that, it's informed action planning that we've done in collaboration with DPHR to start looking at the civil service examinations, the frequency of those examinations, to ensure that we can reduce the vacancy rate in that particular group. Shifting to the right, I'd like to focus on retention. As you can see there, our retention rate was close to 90% pre-pandemic. And then, as most health departments experienced across the nation as a result of the COVID-19 response, retention dropped. And you'll see for us, the retention rate is about 80%. And we're currently focusing on implementing a wide range of strategies, one of which I'll talk about in a moment, our Boost Awards, to focus on retention. Next slide. As I mentioned before, we participated in the PHWINS survey, and a special module in this fielding focused on those who are 35 years and younger. It's notable that a vast majority of 35 and under respondents, and in our workforce, that represents 37% of the workforce. You'll note that they cited retirement benefits, meaningful work, and job security as major factors in their decision for joining governmental public health. And so that's really important, especially as we're talking about filling vacancies and ensuring that we're doing comprehensive recruitment to emphasize those key points into our communications as we pursue recruitment. Next slide. So PHWINS also assessed cross-cutting training needs for the governmental public health workforce. And so as you can see here from these data from PHWINS 2024, all staff and leadership identified policy engagement and systems and strategic thinking as shared training needs. However, all staff reported a greater need for budget and financial management training, while supervisors, managers, and executives more frequently identified a need for community engagement training. Next slide. So when I came before the commission 2 years ago, we were recent recipients of the unprecedented CDC funding to strengthen national public health infrastructure, also known as the Public Health Infrastructure Grant, or FIG. We locally call it Project Invest, innovations that value equity and strengthen teams. And as a reminder, FIG is a 5-year cooperative agreement that has provided $3.8 billion to 107 local and state health departments across the country and to support national partners to provide technical assistance to those groups. DPH received approximately $12 million to date to invest in workforce development, including recruitment, retention, sustaining the workforce, and training the workforce, and to support workforce development planning. The funds were also used to strengthen foundational capabilities of public health. And we are prioritizing work to enhance community partnerships, including our work with Promotoras, which I know you both know very well, as well as emergency preparedness and investments in our leadership. To date, we've hired 13.5 FTE through this mechanism, and I'll share a few highlights from Project Invest focused workforce development efforts. Next slide. So first, I want to talk about our focus on retention. And this is a novel mechanism that we implemented in January of 2024. It's called the Boost Awards. It's a mini grant program where grants are administered anywhere from $100 to $5,000 to teams within PhD. We have bi-monthly calls for applications, and thus far, we've awarded 43 Boost Awards to teams, as you can see on the right, to all teams within the division. Most of the awards focus on team building, staff recognition and appreciation, and professional development. We've learned a number of important lessons. You can see at the bottom, this is an example of a recognition event for emergency preparedness last December. It was widely attended and really appreciated. And I think this, among a number of activities, have been highly rated by the awardees. Just an example, a sample quote on the bottom right, you'll see from one of the participants, it was a good mix of speaking, ceremony, and socializing. I appreciated acknowledging the nominees as well as the winners of each award and hearing about everyone's accomplishments. And I think that's a critical piece of our goal of trying to support retention, which is acknowledging the extraordinary efforts and recognizing our staff for the great work that they do every day. But we've also learned some important lessons about how to improve the program because we have to go through city procurement processes in terms of getting access to, for example, food at an event or things. We have to go through the city procedures. Those administrative procedures require multiple steps. And so just onboarding our staff about how to walk through those has required a lot of additional effort. And that's been an important part of our process improvement. We'll move to the next slide. So I now want to focus on an innovation around trying to bring more training around filling gaps around what we call BEAM, Building Expertise in Administration and Management. As I said from PH Wins, both in the last fielding as well as in the current fielding of the survey, this has been a major need for capacity building. And so to date, we've been able to bring on 42 participants into a kind of multimodal course. First, there's an online certificate course that's been provided by the University of Miami. This is a course that was developed by public health professionals for public health professionals. It's an online certificate course. It takes about 3 months. So there are 6 separate modules focused on strategic problem definition, budgeting, procurement, contracts and monitoring, and financial health. But from the pilot, we realized not only did we need to do the online course, we needed to provide practical examples of how do you implement this in the Department of Public Health. So we work in close partnership with subject matter experts who then provide very specific examples and provide guidance to the trainees about how some of these principles are implemented here at the department. And so from the evaluation data, we see that 95% gained knowledge and skills that they can apply in future PhD work, and 80% would recommend this course to colleagues. And just a sample quote from our qualitative assessment, one of our participants said the BEAM course provided helpful templates and frameworks for problem solving that I had not encountered before, and I could see myself using in my work. Next slide. Also under Project Invest, we partnered with the Public Health Institute to conduct a mixed methods workforce analysis and gleaned important insights to inform recommendations that focus on recruitment, retention, and training, and expanding community and stakeholder engagement. You've received the report in advance, and I'm happy to answer any questions about it. Just in terms of the recommendations that you'll see on the right side of the slide, we're currently moving forward with many of them, and others are currently in the early planning stages. So, for example, we're working with HR to reduce the time to hire for certain positions, exploring how we can increase the frequency of civil service exams, which I've mentioned before, and looking at how HR can look beyond exit interviews with departing staff to invest in stay interviews for selected early career staff to better understand what's keeping these employees at DPH. We're also working with the San Francisco Health Services System to bring new wellness classes to staff across the division to try to increase access to those for all of our staff that are distributed across a number of sites. Moving to the next slide, please. So some of our Project Invest or FIG next steps. So around workforce development in terms of reaccreditation, CLI serves as the Domain 8 champion, and we're in the process of responding to questions from the Public Health Accreditation Board, and we're hopeful that that will be successful in moving us towards reaccreditation. We're also analyzing data from PHWIN's 2024 and the 2025 DPH-wide engagement survey. We had a 91% response rate in PhD, the highest response rate of any division across the department. And those data will be important to inform future action planning and the investments we'll make in our workforce. I'm also excited to say we'll be launching a leadership academy for our directors at the end of this year. And as I mentioned, we're expanding wellness offerings across the division. And finally, I just wanted to mention that we have a population health fellows. We'll be bringing on 2 new fellows in August. We'll be spending 2 years with us to be able to hopefully become competitive for future positions within the division. So it's an important workforce and pathways program. Finally, we have, as part of Project Invest, we focus on foundational capabilities, as I mentioned, so strengthening neighborhood level emergency preparedness and response planning. That's led by Dr. Andy Tenner, and I'm sure she and others from her team will be able to talk about the exciting work that they have underway. And then integration of community health workers and promotoris work, which I know Director Ursula Ford shared with you from the Office of Equity and Community Engagement. That's vital collaborative work that we've been able to implement. So to the last slide, just to summarize, PhD has made major strides in addressing workforce priorities and accreditation standards. Diversification of the workforce, which I've shared with you, including leadership positions, as well as launching robust multi-component trainings to address priority needs such as budgeting and financial management. We have ongoing work to reduce vacancies, bolster retention, and strengthen our foundational capabilities. And it's critical that we continue to collaborate with DPH HR and invest in teams through our examples like our Boost Award mechanism, and looking at advancement opportunities and investing in our staff's well-being, as well as focusing on pathways to nurture future public health professionals. And I'll just close by saying the CDC Public Health Infrastructure Grant has provided us key support for training infrastructure, although I have to mention that through federal funding uncertainty, and again, this mechanism is funded through 2027, and we need to focus on sustainability to ensure that our ongoing investment in our capacities and capabilities is maintained so that we have the public health workforce we need to be able to tackle the challenges we face at the community level. And I'll close and thank you for your attention and happy to answer any questions you have.
Is there any public comment in the room on this item? I do not hear, I don't see any, and there's no remote. Pass away.
I have a couple more questions.
Please.
Thank you for answering my previous questions, but I want to get back to the slide that there's a couple I'm most interested in a little bit more information.
Sure.
And one was on the Boost Awards
Please.
for starters, which is on slide 13.
Mhm.
And I mean, I think this is a great program, but
Thank you.
I assume that there is an application process to it. And in the focus of the applications and those that are accepted, kind of can you share some of the different applicants' goals?
Sure. Absolutely. So So to clarify, we have bi-monthly calls for applications. And so we actually encourage not only the directors or managers to apply, we actually encourage frontline staff to work with their teams to be able to put in the applications. A great professional development opportunity for them to be able to put in these small grant applications. We make the application process as easy as possible. It's just kind of define what are you trying to accomplish, and many of the goals actually align with what the mechanism was designed to support. Things like employee recognition, staff recognition, team building, supporting better intra-team or inter-team communication. Some of our grants go to more than one team or more than one branch so that they can work effectively together. So those are just some of the types of things that people apply for in order to support their work. And so the example below about the public health emergency preparedness and response appreciation celebration, that's like a perfect example of the types of activities that are being supported by the Boost Awards. I also want to share that we have had 43 awards funded. This cycle that just ended, we have over 14 applications for new Boost Awards. So we're seeing increasing interest in the mechanism to be able to support teams here within the division.
And how is it, how is the Boost Awards disseminated throughout the department? So
Great.
people know both leadership and staff about them?
Great. So we have a number of mechanisms to do that. So first, the PhD is eligible to receive, any of the teams within the Population Health Division are eligible to receive a Boost Award. So we have a SharePoint site that we've created. It's called the Training Resource and Information Portal, or the TRIP, that's hosted by CLI. And that has all of the information that you could possibly want about what it would take to apply for one of these awards. What are some of the eligibility criteria, and if they have information, both questions about pre-award, what would it take to apply for one of these awards, and then post-award, how to manage one of them once you receive them. We also run office hours, and we do that before each cycle so that if people have questions about what are some ideas or any specific targeted questions about the application process itself. And then once individuals are once they receive an award, we have an orientation process with them to make sure that they have the tools and the support that they need to successfully implement the awards that they've applied for.
Great. Then I wanted to know more about, too, in the following slide with 42 participants in the two cohorts, looking at building administration and management and the, online coursework and Beam. Can you give us just some examples of the application of, more specific application of how, what they learned in their certificate program was practically applied?
Absolutely. So some examples, and I'm very excited that Andrea Henkel, our training officers who leads that course very ably, could also provide some additional comments here. But some examples. For example, we have a whole module focused on procurement and what are the requirements for procuring, whether it's services or other resources here within the division. What are the steps about going about that? How do you work with fiscal? How do you put together a purchase order? So these are very practical examples. Vendor agreements. What is the contracting process? How does solicitations work? So specifically here in the division, but those are just a few examples of very practical applications of some of the larger concepts that folks learn through the online certificate course.
What is the time it takes, or what is with the online certification? Is it X number of hours? I mean, X number of days, evenings? Is it Zoom, or is it,
Sure.
just, standard curriculum online with interaction or no
Yeah,
interaction?
the online certification is purely asynchronous, so folks can take it at their own time. Of course,
Okay.
because typically it's over a 3-month period, and there are 6 modules. I think it's 16 hours total of instruction. Is that correct? More, 15 and 20. Thank you. And so then, in order for one of our staff members to take the course, they get support from their supervisors to be able to use work time to be able to complete the coursework. In addition to that, associated with, periodically you'll do a couple of modules, and then there will be a synchronous session that Andrea facilitates with the subject matter experts and with the participants to be able to get the very specific information to DPH, like on procurement or on vendor agreements, for example. And so that will be a facilitated discussion that typically it was around 90 minutes, I think, and then it would vary. Yeah. Did you hear that, or I can repeat that
Yeah.
if you need it? So 60
No,
minutes
yeah,
and a
I did
30-minute
hear it.
additional discussion.
Within the course, just because some of these online courses, I'm, just curious.
Some are better than others.
Yes, correct. Some are better than others, and I know you vetted this one. But do they have, as part of the, completion of the course, do they have to put together a project? Or is it just didactic, basically only?
The course itself does not have like some type of project that they need to complete. And in fact, what the University of Miami is encouraging is that they are actually encouraging the process that we undertook with the course, which was, learn these core principles through this online course, and then really think about its direct application in the public health settings where staff work. So we didn't include a project per se, but what we were encouraging folks who were going to apply to participate in the course is, we hope they're going to use this material, that either you were a manager that wanted to build those skills, or you were a staff member that wanted to move in that direction. And this you saw as a really great professional development opportunity to get these skills to make you competitive for future positions where you would need to use them. So I think that was the idea, is that it would be practical application after getting this foundational knowledge through the online course that was really designed by public health professionals for public health professionals.
That's great. Do the participants in these two cohorts like apply to you first or to your group, and then you say yay or nay, and then you go ahead and, foot the tuition or whatever it might be? Am I?
Exactly right. They apply to us. We tried to get to yes. There's very few people that we're going to deny participating. Obviously, we encourage their staff supervisors have to approve for their participation because of the time requirements. And then we through the public health infrastructure grant, we've been able to secure the resources to support their tuition for the participants. And then they receive this online certification after they completed the course.
No, I appreciate it. And probably in the same vein,
Okay.
is the Leadership Academy. And if maybe you could just enlighten me a little bit more on the Leadership Academy, who applies, what are the individual goals, et cetera.
Great. So I'm also accompanied by our other training officer, Denmark Diaz, who's helping us to lead that effort as well. It's a comprehensive process that we're going through that really is starting with it's grounded in equity. So it's leadership competencies with an equity focus. We're working in close collaboration with the technical assistance provider that we had assigned to us through the public health infrastructure grant. They're called Health Resources in Action. They've developed leadership development courses for public health departments across the country for many years. So in collaboration with them, we've started first trying to understand what we wanted to design a theory of change. What are some of the ways that we want to try to best support our staff through our leadership? And so we went through a comprehensive process by talking to our directors, talking to our executive team, talking to staff. What are those leadership competencies that we want to ensure our leadership possess? And then developing that leadership, that theory of change. Now we're in a design phase where we're working closely again to try and understand how are we going to operationalize those competencies? How are we going to assess our leadership? And this is, again, is a pilot that's being designed specifically for the directors. Understand what their self-assessment is based on those competencies. And then we'll be developing a targeted curriculum that will be helping to enhance skills and strengthen capabilities in those areas that have been prioritized. And our goal is to be able to implement that Leadership Academy, which right now, again, we haven't completed the design phase, but once the design phase is completed, we'll have approximately 6 to 9 month Leadership Academy where we'll be meeting with the directors regularly. We'll have a number of interactive components. The hope is that we'll also include a 360 evaluation and a number of other interactive pieces to be able to engage our leadership and help them receive also individualized coaching and support for their work across the multiple areas we work with within BHD.
Great. One more question.
Please.
A little more on the fellowship
Mhm.
and where your applicants for the fellowship, where do they come from?
Mhm.
And what is the length of the fellowship? And I know you said the goal is to be able to integrate them into the public health sector. And maybe you could just
A little bit
let
about
me
that.
know a little bit more.
Sure. So last time I was with you, I talked to you about a pilot program that we launched, again, through the Public Health Infrastructure Grant. We created a 9-month program to bring on folks to be able to with experiential learning, with strong mentorship to be able to prepare them for future applications to positions within the department. It became very clear from that early pilot, a lot of important successes, but it was very clear that that period needed to be longer, to be able to have a long enough runway for people to be able to apply, to be able to get on an eligible list, and to be able to come on to potentially apply for a permanent civil service position. So from learnings from the pilot, we've extended that period to 2 years, and we've been able to successfully integrate this into a 99-10 civil service public health trainee position. So there are 2 public health trainees. It's a 2-year fellowship. So we put out the calls through standard recruitment strategies through the city. We had over 400 applications for the slots that we originally had, and then because of budget constraints and the ability to bring on public health trainees, we have 2 trainees, public health fellows, population health fellows that we'll be bringing on in this cohort. Our hope is that we'd be able to bring on future, much larger cohorts to be able to support the areas that we're trying to bring folks into. For example, our health worker series, our data scientist series, working to our health coordinators. So areas where we're identifying gaps into environmental health inspectors as another example. So where we've had challenges in bringing folks on board, we want to be able to have very focused training opportunities for them and to be able to provide core mentorship, a core curriculum, and experiences across the division to get folks excited after that period to end to meet the qualifications to apply for future positions within the division.
Great. So it's kind of a work in progress depending on funding.
We've done the pilot.
Wow.
We have the resources for 2 public health trainees that are going to be starting with us in August. So we're very excited
Great.
about that.
Where are they coming from? Like,
Actually, both of our applicants are from the Bayview. So
okay.
they're local. Both have completed their undergraduates and are one who has a strong interest in environmental health, and another has a very strong interest in a lot of our community health work, in particular our work with our promotores. And we have
they
excellent
want to
mentors.
get their master's in public health at UC Berkeley.
Yeah,
Hopefully.
that will definitely be a conversation with each of them. Actually, we know one of the applicants is very excited about moving forward with an MPH, but it's definitely trying to get additional training in public health would definitely be a priority.
Okay. Thank you, Judy.
Yeah, I just have one sort of general observation or question.
Please.
I was looking at this graph where the 37% of the workforce is under 35. And of those, there's really strong enthusiasm for both the retirement benefits and the ability to do community work and then job security. I was really surprised actually, because most of the people I know who are under 35 are not thinking far enough ahead to get to those places. But I'm hoping that with that as their drive, that creativity is also going to be in there, or you're going to spark that creativity and their willingness to do the work.
Yeah, no, I agree wholeheartedly. I think in the terms of the way that this specific question was asked, that domain, specifically my ability to innovate or be creative in my work, was not assessed here in the way that this was worded. However, in PHWinds, and we haven't seen the final data set yet, but in PHWinds, that is one of the questions specifically on reasons why people want to stay within the organization is there's a real desire to be able to create a nurturing environment to support creativity and innovation. So I can come back to you when I have those data, and I'll be happy to share what that data point is for the division.
Good. Well, it speaks, I think it speaks to the fact that you'll have an experienced workforce as they stay committed to the work.
Right. And that we have to create an environment where that's nurtured and where folks have an opportunity to innovate and support their community health work. Absolutely.
No, I appreciate it and thank you. And are you, I know in your very last point, you noted for the training infrastructure, it's the federal funding going forward is a bit of, who knows sort of thing. Are you and your department concerned at all with your the words diversity and equity in not in what you do, but in the grants, if they're in the title of the grants? My understanding, that's been a red flag in for NIH and for other academic institutions. Is that one of your concerns? I mean, I'm sure it's a concern,
Yeah.
but a semantic consideration in, further future applications. I
Sure.
mean, I don't know.
Yeah, no, thank you. I appreciate the question. So I think when for any of our awards, federal awards, whether it's the NIH or CDC or others, that whatever guidance that we've received, including compliance with executive orders, all of that information is taken here. We are working very closely with our city attorney, the Population Health Division, the Department of Public Health, and in terms of what the implications are for our awards and us to be able to move forward. An example is from one of our summer HIV/AIDS research program, which is an NIH-funded award. There was a request specifically to modify our abstract in order to be able to move forward. We made minor, fortunately, we didn't have to make very many changes, but minor changes to language that was required in order for us to receive our notice of award. But I think for all of our groups, we're working very closely, or all of our groups that receive federal funding, we're working very closely through our policy branch, led by Eduardo Cito, who's behind me, and working closely with our city attorney to really understand what the implications are. And just to acknowledge the uncertainty around the federal funding landscape and some of these requirements in terms of future funding received to support our vital programs. Thank you for the question.
No, it's not a question I wanted to
Sure.
ask, but, it's something I know even in some of the things that I do, I've had to alter my semantics to what diversity and inclusion is. So, but thank you very much for the presentation, and I really, appreciate the update. And it's um, a your work is just wonderful, but I really appreciate the information on an updated basis coming to this committee to kind of we can see the growth. And it's just you and your department, not only to the division, but to the whole department, is just a significant contribution to the whole department moving forward. So thank you very much for all of your work and your colleagues for being here as well. So
Great.
thank you.
Thank you very much. Really appreciate it.
All right, we can move on to item 5, emerging issues. Is there anybody in the room who would like to make comment on that? And commissioners, any? All right. Public comment. This is a time when anyone in the room can make comment about something that's not on the agenda. I see no comments there. And commissioners, a consideration for adjournment.
I so move to adjourn.
Second.
All those in favor?
Aye.
Great. Thank you, everyone who watched and participated, and for all your great work for those of you in the room. Yeah, give me 30 seconds to take us down before you. That's it.